Okay, dear participants, respected teachers, our keynote speaker, Dr. Vipul Gupta, and all the neurologists, radiologists, young neurologists, all the neurologist students. Good evening, everybody. Welcome you all to our today's webinar meeting. On behalf of Society of Neurointervention, I am Dr. Subhash Kanti De. I am working as a Associate Professor of Neurology, Bangabandhu Sheikh Mujib Medical University. Today's program is jointly organized by Bangladesh Society of Neurointervention, Bangladesh Society of Neurologists of Bangladesh, and Bangladesh Society of Radiology and Imaging. So today's topic is the vascular imaging in the management of stroke. Our keynote speaker is Dr. Vipul Gupta. He is working as a chief neurointerventional surgery and co-chief stroke unit Artemis Agrimin Institute of Neuroscience, Artemis Hospital, Gurgaon, India. And today we feel honored because our guest is two guests. One is the Professor Kajiddin Mahmood Sir, who is working as a director of National Institute of Neuroscience, Bangladesh. He is our direct teacher, and he is actually the teacher of the teachers. And another chief guest is honorable guest is Professor Firuz Ahmed Quraishi Sir. He is also our teacher and teacher of many neurologists, and now working as a president of Bangladesh Society of Neurologists of Bangladesh. Our in panel discussion, welcome Dr. Shahniar Nobi Shakil. He is a Secretary General of Bangladesh Society of Radiology and Imaging, and working as associate professor of radiology imaging in Dhaka University, and he also holding post of the Dean of Faculty of Medicine, Dhaka University. And our Secretary General, Professor Kazi Mohibur Rahman, along with us with all activities. And today's program, webinar is chaired by Professor Sharifuddin Khan, who is working as a president of Bangladesh Society of Neurointervention. Before starting the topic, I want to utter a few words about the topic, because now this is the pandemic situation due to the coronavirus infection. So before and after coronavirus pandemic, our main culprit of the health sector was the non-communicable disease. And stroke is the major part of the non-communicable disease. And I want to mention here that a stroke always the clinical diagnosis, but without imaging facility, without neuroimaging, you cannot classify the stroke, and without vascular imaging, that is the neurovascular imaging, we cannot locate the specific location and we cannot start our specific treatment. So today's topic is very much important about the diagnosis of the stroke and also about the specific management of the stroke for the welfare of the patient. We want to welcome Dr. Vipul Gupta. In his busy schedule, he manages his time to ventilate some knowledge about vascular imaging to us. He passed MBBS from Maulana Azad Medical College, Delhi University, and completed MD Radio Diagnosis from Safdarganj Hospital under Delhi University. And he was trained in neurointervention in AIMS and working as there as associate professor long time up to 2005. And in 2005, he completed fellowship from the Foundation Rothschild in Paris, France. And he also worked as head of the neurointervention and stroke unit in Max and Medanta Hospital, now working as head of the chief of the neurointervention surgery and co-chief of the stroke unit in Artemis Hospital. Is very familiar to many neurologists of us because many neurologists, neurosurgeons, and radiologists attended his program in Delhi many times. So I now welcome Dr. Vipul Gupta to present about the topics. Please, sir.
Good evening, everybody. It's a great pleasure and honor, and with all the societies involved of neurointervention, neurology, and radiology. And so I will now start my screen sharing, and hopefully this will be a productive session for all of us. So this is a very interesting topic, of course, vascular imaging, and all of us know in stroke and neurointervention, we depend so much upon imaging. And in this limit of 1 hour, I will try to cover as much as possible. And later on, we can have questions, or later on, we can have interactions as well. So I've divided my talk into like 3 parts. And role of imaging in acute ischemic stroke intervention, how we decide. Then vascular imaging in deciding upon pathology and management of stroke, post-acute stage. And third session is a very specific one where recently we have been working on is vessel wall MRI, and a simplified approach, how it helps us in differential diagnosis of some of the challenging patients. So talking about acute stroke imaging, it really came into being when in 2015, all these positive trials were published about effectivity of mechanical thrombectomy in reversing acute stroke. And these guidelines came from AHA and ASA in 2015, where they laid it out which patients we can select for ischemic stroke thrombectomy. Now here, this was very important. Here in this, they mentioned aspects of more than equal to 6 in terms of imaging, and there should be a major vessel blockage. And that is where cross-sectional imaging and vascular imaging came into acute stroke. So what do we want to really know what are the goals of acute stroke imaging? So number one, of course, we want to know that there is a major vessel occlusion, then only you like to intervene. You want to know that how much is the infarct. The infarct should be small, it should not be too big. And of course, we want to know that there is a penumbra, that means there is an ischemic zone which is still viable. And first of all, of course, that we want to exclude hemorrhage. So these are the goals of acute stroke imaging. And there are many different ways by which we can achieve them. We can achieve them using only CT scan. In these cases, what we do is CT scan and CT angiography. You can also study CTA source images as well. Or we can do NCCT, CT, and CT perfusion. This is what we were doing when I was in Vedanta. Or you can do some centers in world are doing MRI DWI combined with MRA, and if need be MR perfusion. Or one can do a combined approach like now we are doing at Artemis. What we do is we quickly do CT and CTA, and then to look at the core, we do one sequence DWI imaging. So these are the various different approach by which you gather that information. Now, hemorrhage, we know CT scan. So which modality shows us what and how does it show? So CT scan, of course, shows us the hemorrhage pretty well. But even MR is pretty good at it, but sometimes it needs an expert interpretation. Major vessel occlusion, of course, CTA is very good, is very quick, and is better than it shows us the whole arterial tree very quickly and more details than MRA in acute stage. When we talk about the ischemic core, then MR scores over CTA, because in DWI we can see the ischemic core better. And NCCT is the least effective, but I will show you some subtle signs how we can diagnose early infarction on NCCT. CTA source images are better than NCCT, and sometimes you can use then CT perfusion, and including cerebral blood flow, CBV, and transit time, and I will show how CT perfusion can also be used to detect a core. Then when we come to penumbra, whenever we know there is a major vessel occlusion with a small infarct and a big deficit, then we know there is a penumbra. So either it can be a clinical core mismatch, that means the deficit matches the infarct core, then we know there is no penumbra. When the clinical deficit is much bigger and the infarct we can see is much smaller, then we know there is a penumbra. Another way is that we can do a perfusion imaging. If the area of hypoperfusion and core are the same, then we say they are matched and there is no penumbra. But if we see a much larger area of hypoperfusion and the core is small, then we know there is a penumbra. So these can be two basic approaches by which we can see penumbra. As I mentioned, this is our protocol. We do a CT CTA, and then quickly in 2 minutes we get a DWI lesion. And whenever there's a DWI clinical mismatch in our department, we say, okay, there is a penumbra. And on CTA, if we have seen a major vessel occlusion, then we go ahead with intervention. CTA is very, very good. I will just skip these slides because it really helps us to see the whole arterial tree and make a quick decision. Although my talk is on vascular imaging, I will touch a little bit upon NCCT. NCCT still remains the basic main investigation, quickly rules out intracranial bleed. We can see some early signs of infarctions. And of course, for IVTPA, that is all you need. And one can go ahead with IVTPA. We don't waste time of CT or MRI before giving IVTPA. So IVTPA decision taken is soon after CT scan. Now, this is very important because we want to do aspect scoring. So in aspect scoring, there's score of 10. So you can see M1, M2, M3, M4, M5, M6. These are 4 of them. Then there is an insula, lenticular nucleus, internal capsule, and caudal nucleus. So 10 scored. And for each area, which is we see a hypodensity, we deduct it. And as I told you initially, 6 or more than 6 is regarded as good score for neurointervention. Now coming to some early subtle signs on CT scan, because one has to be very confident in emergency situation that you are not missing things. So this is like hyperdense MCA. Whenever you see this hyperdense MCA on one side, you know there's a big clot in the middle cerebral artery. And sometimes you can see something like this, which is known as MCA dot sign. When the distal M2, there is a clot there, you may see on cross section and say MCA dot sign. Obscuration of the lentiform nucleus involvement, you can just see the gray-white matter differentiation is gone. Sometimes it's pretty subtle, but as I will show you, sometimes you can change the window and see these signs much better. And here, these are insular ribbon involvement here in this particular patient. And as I mentioned, the same image, there is something probably here when you change the window, and you can see these hypodensities much better in these patients as compared to regular one. For example, here, if there is a doubt, then you can change the window and try to look for the infarction. So one should always play about these images on the CT scan console. I mentioned CTA-SI. So the source images of CTA sometimes can show the hypodensity better. Like in this patient, there was a hyperdense MCA. There is some subtle signs of infarction, but one is not very sure how big it is. But CTA source images show there was a very big infarction involving. So although we did the intervention, this was one of the first few cases we did around 7-8 years back, but the outcome wasn't good. As I mentioned, CTA remains the mainstay to us. It shows us how the aortic arch is. It shows us only proximal cervical occlusions as well. It shows us intracranial circulation, including any collateral flow as well. It can show us tandem occlusion, like here in this case, there's an IC occlusion as well as MC occlusion. And it can again show us, like in this case, there's a dissection here, then there is a loop, but there's a good communicating artery and a distal MC occlusion. So all these findings, and sometimes when there's a severe tortuosity, we know that we have to be prepared to use catheters like SIM catheters. So CTA actually gives us the whole roadmap, not only the diagnosis of major vessel occlusion, it helps us to plan for intervention as well. So after NCT, CTA, and CTA-SI, some people use collateral scoring in these patients. That means on CTA, if you see good collaterals, you will know there is a good penumbra because the tissue will not infarct, it is only ischemic. So this is one of the common MICHF system of collateral scoring which is used. It is graded into 3. When there's a contrast opacification of the sylvian branches, then we say it's very good collaterals. Or only when some vessels are seen, like in pink, up to the sylvian fissure, then we say grade B. And when only distal vessels, like in green, are seen, then we call it a grade C. So the prognosis will change. Whenever you're seeing very good collaterals, you know the core will be small, the true infarcted zone will be small, the rest of the area is only ischemic, and these will be good cases for intervention. While as compared to poor collaterals, the infarct will progress much quicker and will not be good cases. And this was published by one of my seniors, Professor Mayank Goyal from Calgary. He's a very renowned neurointervention teams of stroke. That in this, they did multiphasic CTA, again, to assess collateral flow. So sometimes when you can't do DWI or CD perfusion, one can use collateral scoring to judge whether there will be penumbra or not. So from NCCT to CTA, CTSI to collateral scoring, what we come around to is perfusion imaging, which is pretty useful in some situations. So through the perfusion, you can get cerebral blood flow, cerebral blood volume, mean transit time. And nowadays, what we do is time to maximum peak is pretty important. Now, this was the trial, Diffuse 3 trial, and these are the criteria which they are using nowadays in CT perfusion. When that means the ischemic core volume should be less than 70 ml, mismatch ratio should be more than 1.8 is compared to ischemic area, the penumbra zone versus the zone which is infarcted. The volume of mismatch should be at least more than 15 ml. How do they assess the core? By reduced CBV. So whenever cerebral blood volume is less than 30% of normal, they know that zone is infarcted, you cannot revive it. And the penumbra is set by T max, time to maximum peak. If there's a more than 6-second delay, then we know there is a penumbra. And nowadays we are getting automated system, this is known as rapid system, by which automatically the CT machine will generate this kind of map. Like in this patient, all the pink area is the core, and it will generate a volume of 23 ml, while all the green area by T max is the hypoperfusion area. So the volume of hypoperfused area is 128 ml. So straight away they get a mismatch ratio of 5.6 and mismatch value of 105, and machine will automatically show this within a few minutes, and you know this patient is a good candidate for a mechanical thrombectomy. This is one of my old cases when I was in Medanta, hyperdense MCA. We saw CT angiogram, IC occlusion, intracranial IC occlusion, and you do a CT perfusion. Cellular blood volume here is very low. This is the core, while big area of hypoperfusion on the right side. A good case for intervention. We open up the artery, and next day CT scan will show again. It sort of validates the CT perfusion, only a small infarct in basal ganglia, and we published this case, and patient did pretty well. While in some other situation, like this patient at 540, you do a CT scan, the tissue looks pretty normal, but when you do a CT perfusion, within 10 minutes, you know there's a huge area of infarction. So we didn't do intervention, and the follow-up CT scan shows a large area of infarction in this patient. So sometimes in emergency situation, perfusion imaging can be very useful. Coming to MRI, as we discussed, MR is pretty good for, DWI is very good for core. MRI can only be done, but again, in MR, it takes more time. Patient movement artifacts are much more. So in our center, that is why we prefer CT and CT angiogram. And what you should know that every 30-minute delay, there is a 10% chance of possibility of less possibility of good outcome. So any imaging has to be very fast imaging. So this is a good case, like in one of our patient, MC occlusion, but a small infarct on MR, we know is a good candidate. While a case like this, hyperdense MCA, here maybe there is some infarction, we are not so sure. But when we do MR, immediately we see a large core, we know this is the patient will not be a good candidate for mechanical thrombectomy. And as I mentioned, it has to be very fast because the chances of good outcomes goes away pretty quickly. So rather than very elaborate imaging, you should do very quick imaging, have a protocol in your center, and decide upon thrombectomy very, very soon. There are some situations in which you have to do advanced imaging like MR or CT perfusion. So that means when you're doing delayed intervention, these two trials, DAWN trial and Diffuse 3 trial, showed that we can do intervention up to 24 hours of stroke. But beyond 6 hours, you want some kind of imaging such as DWI perfusion imaging to be sure about the core, and that patient will going to benefit by neurointervention. Nowadays, we are also trying to judge using our MR imaging about the kind of clot we have. So this is the SWI images. In this patient, you can see the blooming. This is a RBC-rich clot. And in this case, there's a fibrin-rich clot, which will not bloom. So, and we are learning now how to optimize our thrombectomy technique for different kind of clots using MR imaging as well. So from acute stroke imaging, I will come to now vascular imaging and pathology, which I think majority of you will be interested in. So coming to now, when we look for the causes of stroke, large vessel disease, one of the major causes, cardiac causes are there. Then there's a small vessel disease, coagulopathy, vasculitis, dissections, and many other reasons. Now coming to atherosclerotic disease, we know most common site is carotid bifurcation, but it can happen carotid vessel origin, it can be intracranial, and probably in our subcontinent, we are seeing a lot of intracranial atherosclerotics. So, now, one thing I would like to tell everybody should realize that most of the strokes because of carotid stenosis are not because of hemodynamic reason, it's mostly because plaque ruptures and they're embolic in region. That means usually plaque ruptures, there's a clot formation which embolizes and causes TI or stroke. And this is very important for all of us to understand in terms of understanding how to manage that patient. So what about the imaging, vascular imaging here? Doppler is decent, around 70%, but is very operator dependent. MRI can easily overdiagnose if you're doing it without contrast, particularly in slow flow situations. It can give rise to a lot of artifacts. CT and contrast enhanced MRI are pretty good to detect carotid artery stenosis, around 9 to 95% degree accuracy. Now, this is very important. How do we measure stenosis? We never measure stenosis by the lumen versus the diameter at that level, but we measure from the residual luminal diameter with distal ICA. This is the Nassau criteria, and that's the way to measure the degree of stenosis. Very commonly, people on Doppler, they measure the cross-section and they report it as 80%, while when you measure by Nassau criteria, it will be much less. So this is something every radiologist should be aware of. When we come to the imaging, what are the important features? We look for the degree of stenosis, length of the stenosis, any ulcerations, any calcifications. We look for any fresh thrombus formation, floating clots, at which cervical level it is. Suppose you're thinking about endarterectomy, then we have to be very, very aware that at which level. Sometimes it's a C1, C2 level, then is not good for endarterectomy surgeon. How is the distal flow? Is the artery collapsed or good? What are the collaterals, or particularly the anterior posterior communicating collaterals or leptomeningeal collaterals? Because that determine how the intervention is or how these patients are managed. And of course, we should not miss the arch and proximal vessels, because a lot of time we see atherosclerosis in arch, which can also be possible for TIA or strokes. So this is like a classical case, a 65-year-old with TIAs, small DWI lesions, severe keratosis. In spite of this severity, a lot of these lesions, if you see, these may be watershed, but these lesions are embolic in nature. So most of these cases, the plaque ruptures or the endothelial gets damaged, there's a clot formation and it embolizes. So it's a mixture of watershed as well as embolic infarctions, which is a common picture in these patients. So these are the base images. So when we do a CTA, we always look at base images to be sure the degree of stenosis. So you have to play around on the console to be sure about that. And this is like base image. This is the plaque. This is the lumen. So you never measure the normal diameter from here. You measure it from the distal vessel, as I mentioned here in this case. So you measure the residual lumen versus distal lumen, and then only you don't measure the diameter from here to calculate the percentage of stenosis. You use this Nassau criteria, and then only we are sure whether this patient needs any intervention or not. Plaque surface, one has to study very carefully. You sometimes may have a smooth surface like this. Sometimes you can have minimal irregularity, or you can have something like this when we know definitely it's an ulceration. The importance is the ulcerated plaques are more commonly result in future strokes. Even in incidental ulcerated stenosis has a more incidence of symptoms in future rather than a smooth plaque. Then plaque one can characterize. Sometimes it can have a fatty core, and sometimes it can have calcifications. So you look at the plaque architecture and characterize it. The calcification is also very important, whether it's concentric or eccentric in nature. So sometimes calcification can be speck-like, it doesn't matter, or it can be circumferential but not complete. So even these cases are good for stenting, but when it is circumferential and dense calcification, these are the only cases where you will warn the interventionist that stenting may not be a good option, but there's a very, very infrequent to have something like this. Sometimes you're going to have very irregular plaques like this, and you should always suspect whether there is a floating clot, because again, if this patient goes for intervention, there's chances of embolism in these patients. Sometimes you can definitely diagnose this floating clot, like this patient with infarction here, and what you can see on CT angiogram, clearly there is a floating clot. This is the plaque, and there is a floating clot here. So in these kind of cases, ideally they have to go for endarterectomy, or we anticoagulate them for a couple of weeks by the time clot dissolves, and then only we take them for stenting procedure. So it's a radiologist's responsibility, and even neurologists should be aware of these findings, and they should be asking their radiologist for it. Sometimes these clots may not be so easily seen, like in this patient, CT angiogram look clean. Retrospect, it looks a bit hazy here, but when we did the DSA, here you can definitely see there is a clot here, and we put the patient on anticoagulation. After 2 weeks, see, now it is very, very clear, and that's the time we could go ahead with stenting in this patient. I mentioned about confusion or artifacts with non-contrast MRI. So like this is a typical patient. She had a small stroke. MRI looks as if the left ICA is occluded, but when you do the Doppler, one can see the flow in left ICA. Because whenever there is slow flow, non-contrast MRI may not show up the vessel. And therefore, it is very important to do either a contrast enhanced MRI or a contrast enhanced CTA in this patient to be sure. The same patient, when we did the DSA, the artery was patent. Also, there was some clot there. And after some thrombolysis, the flow got better in the artery, and the Doppler also showed improved flow. And later on, patient could go ahead with endarterectomy. This is also pretty common, like in this patient with severe stenosis and slow flow in the ICA. If you do non-contrast MRI, it will show as a collapsed artery with no flow in the ICA where the artery is patent. The importance being, if the artery is patent, one can go ahead with endarterectomy stenting. Like in these patients, once you open up the artery, the flow improves and the artery diameter also improves in these patients. Also, one has to realize some of these arteries which are completely occluded in acute stage, even in atherosclerosis, they may open up in future. So we always advise a repeat imaging of some sort after 3 months or so. Like this patient had ischemic stroke. The initial CTA showed completely occluded artery. This artery was filling retrogradely up to this level, but on follow-up CT angiogram, you can see the artery has become opened up. And again, as I said, once it opens up, it can again cause embolism, and one can do a stenting or an endarterectomy. Like in this case, stenting was done to open it completely so as to normalize the blood flow. As radiologists and neurologists, we should also be aware sometimes it can create confusion that which territory may be infarcted, but it may be involvement of some different vessel. Like in this patient, this is a classical PC infarction. You think vertebral artery has to be stenosed. But when we did the CT angio and observe it carefully, what we can see, the right ICA, the ICA is reversed here, is the left one was completely occluded. And because it was giving rise to fetal PCA, here the ICA occlusion actually caused PC infarction. Similarly, if there is a dominant ACOM and the opposite AC is filling from the same side, patient may have ipsilateral symptoms. So you should be aware of this arterial variation and look for them in your vascular imaging so as to not miss this patient. It is very important to assess the collateral flow, because any intervention is done that will tell us, how much hemodynamic change and what are the chances of complication. For example, this patient has small infarctions. Here you can see the left ICA not only looks smaller, it looks fainter. That generally to me indicates very severe stenosis, and that is why non-contrast MRI is not showing it very well. Here you can see severe ICA stenosis. This artery looks diffusely narrowed. It's not narrowed, it's just a collapsed artery. Once you do intervention, it will expand. So you should never be reported as long segment stenosis. It is just a collapsed artery because of slow flow in the artery. This DSA shows a good artery here, and we intervened and opened up the artery. And as you mentioned, whenever there is a severe stenosis with no good collective, no good ACOM or PCOM in this patient, hemodynamic changes can be massive after intervention. And this patient developed hyperperfusion syndrome after 14 days. You can see a lot of cerebral edema on the same side after 10 to 14 days of intervention, and we have to manage accordingly. So again, whenever you see lack of anterior posterior communicating artery, severe stenosis, and a lot of leptomeningeal collaterals, you can warn your interventionist. And as an interventionist, you can be aware that this patient may land up in hyperperfusion syndrome, and we take precautions accordingly. Now coming to intracranial stenosis. Now intracranial stenosis, again, you have to analyze that what are the pathology, what is the etiology of stroke in that patient, because it can be artery to artery embolism, that is plaque rupture and causes embolism, or it can be local branch occlusion, or it can be severe stenosis causing hemodynamic low flow in the artery, or it can be combination of all of those. And this will also help us to decide which patient needs intervention or not. Now, when it comes to intracranial stenosis, we rely on DSA. That means on CT, MRI, if we see, but the final decision only taken on DSA, because intracranial arteries are smaller, and CTA while and MRI good enough for carotid, intracranial stenosis, DSA is much better. Like this patient, severe stenosis, recurrent symptoms on medical therapy. When we did DSA, and in DSA, we'll always do a 3D imaging in these patients. And the 3D imaging clearly showed the reason behind recurrent symptoms. There's a big ulceration in this stenosis. And it also helps us to profile and make accurate measurements for any stent placement and profile this stenosis very, very well, that this is a severe stenosis with an ulceration, and no wonder this patient needs intervention. Again, as I said, MRI doesn't show it very well. This patient had recurrent TIA. MRI shows as if there is complete occlusion, but when you do a DSA, you can see severe stenosis involving the MCA bifurcation as well. And as I mentioned, we always do a vaso-CT and a 3D imaging in this patient to study. Here we can see now the stenosis very, very well in all the different planes and make very accurate measurement for possible intervention. And this patient has a pica infarction. Again, MRA shows as if the vertebral arteries are gone. You can't see the basilar artery. But again, when you do contrast enhanced imaging, you can see there is, these are patent, but there's a severe stenosis of vertebral artery, but DSA profiles it the best. Whenever there's a calcification, CT angio can create a lot of confusion, and DSA showed a very severe stenosis here. The right vertebral was occluded, and no wonder this patient had recurrent symptoms. And MRA and CTA, they could not define it very clearly. And here you can see the anterior spinal artery as well. And as I mentioned, these also images help us to study the perforators, the vaso-CT. The vaso-CT is what we do intra-arterial injection of dye and get a CT scan-like image, but these are 0.1 millimeter in resolution as compared to around 0.5 millimeter with regular CT angiogram. These are obtained in DSA lab, and we can study each and every perforator very well. And we will do this kind of imaging, even like this basilar stenosis after stenting. We'll again do this imaging to study the perforators and the stent placement as well. So Again, another things we have to be very careful about, look for clots in intercranial stenosis, because if anybody intervenes very early and when there are floating clots, it will cause a complication. Like in this patient, looks like a severe stenosis. But again, when we did the vaso-CT, you can see this is the stenosis, but there's a floating clot like this. The plaque has ruptured and formed a floating clot. And in these kind of patients, we like to put them on anticoagulant for some time, clean up the clot, and then do a repeat imaging to really assess the degree of stenosis. And a lot of these patients, which look like severe stenosis initially, but later on follow up, they look pretty well. Another patient with infarction, severe MCS stenosis, again on DSA, severe stenosis, but when you see DSA carefully, there's a lot of floating clots there. So this patient will need anticoagulation for some time. Again, we did intervention. After the clots cleared up, we opened up the artery with improvement in perfusion. Another patient with severe MCS stenosis, DSA shows the true extent of it. Once you do angioplasty and stenting, what is important in this case is look at the perfusion change. This is before. Here you can see a lot of leptomeningeal collateral. So this is a warning sign that there's a very severe hemodynamically severe stenosis. And these kind of patients can develop hyperperfusion syndrome, swelling and bleeding. And this is soon after you can see the change in the perfusion. So whenever on imaging, on angiogram, you see picture like this with leptomeningeal collaterals, to me it's a sign that this patient may end up in hyperperfusion if you open up this blood vessel, and you have to be very careful about it. And we also study vaso-CT and the plaque architecture of intracranial stenosis, like this patient, severe intracranial stenosis, recurrent embolic infarction. So this is again the vaso-CT 3D images. You can see this is the plaque. You can see heterogeneous plaque with a lot of calcification and hypodense area. And no wonder this was a complicated plaque which was causing recurrent embolism in these patients. Now coming to another part, which is I'm very fond of teaching, is dissections. So we see a lot of young patients in India, and I'm sure you must be seeing in Bangladesh as well, of dissections which causes stroke, and they're frequently missed on imaging. So dissection may just result in mural hematoma, or dissection may result in subarachnoid hemorrhage and intracranial disease, or dissection may result in intramural hematoma along with floating clots in the parent vessel. So cervical dissections are common in internal carotid artery, but they can happen in vertebral as well. And in a lot of cases, they are multiple in nature. Now, it's very important that in ICA, they always start distal to the bulb, and they tend not to extend beyond the petrous portion. And in vertebral artery, they're more common in V2 and V3 segments. So just to show you a typical case of, this was a young man with multiple small infarctions. And MRA, this is one of the classical pictures of dissection. So what are the imaging signs here? There's the abnormal contour of the blood vessel here. You can see it's narrowed and dilated, then again narrowed, and it always starts beyond the bulb and finishes at petrous ICA. There's a focal narrowing with distal dilatation. Then there is in this case, there's almost like a dissecting aneurysm in this patient. The bulb is spared in these patients. And there is a narrowed eccentric lumen with a mural thrombus and an intimal flap, which is very well seen on fat suppressed T1. So whenever you suspect dissection, one has to see a fat suppressed T1. Here you can see there is a mural hematoma, which is seen very well like this patient. This is the MRI images. This is the cross section. You can see a bright clot in the wall, and this is very diagnostic of dissection. Sometimes dissection signs can be pretty subtle. Like this patient was referred to us for stenting. There's a loop here, and what you can see, there is a flap here, and this is the clot there. So this is clearly a dissection in the loop. And in most of these patients, the area of involvement is much more than what you see. This patient on follow-up, what you can see, the artery has now opened up. In this area, it is healed. But in this area, on follow-up, it has developed a small aneurysm. So that means the whole area was actually dissected, which we couldn't see before. So the learning points here can be that dissection signs can be very subtle. Most of the dissections, they can heal and change, but they may develop further aneurysmal change, and the extent of damage is much more than obvious than radar. So whenever you see a young patient with stage-looking ICA, keep this in mind and do a dedicated imaging to look for dissections. Again, showing a 47-year-old male patient with left-sided weakness and speech difficulty, small infarctions. These are classical dissection. Bulb is spared, then the artery tapers off and closes off. And there's a good anterior communicating artery. Now you have to realize dissection, it is much more common that the artery may open up on the long-term follow-up. So this patient on simple antiplatelets, on the follow-up, you see the artery has become almost like normal, but you can see some irregularity here. And in the petrous IC, actually one can see the flap as well. So we just continued antiplatelets for a short while. So in dissections also, we always recommend repeat imaging in these patients. Now coming to posterior circulation, this patient present with a large pica infarct, young male, something like this, always think about whether there's a dissection. So these are one of these very typical CTA finding. So you can see this is the left vertebral artery. And again, as I said, we have to see base images to be very, very sure. And here you can see it is narrowed here and then becomes normal diameter in that area. So this is very typical of that area in that just before it pierces the dura, the artery is dissected. And the same thing if you see on fat suppressed T1 in this area here, you can see the eccentric clot in the wall. So this makes the diagnosis 100% certain. You don't need any more investigations. And as I said, a lot of this artery will open up on follow-up. So just to summarize, whenever there's a dissection with a mural hematoma, and on MR, on head suppressed T1, it will look as a very bright signal. And this is what we should look for in dissections. Interclinic dissections can also happen, like this patient, young man with posterior circulation stroke. And this is the MRA. You can see some strange flaps here. So you should suspect this is a dissection of the basilar artery. But when you do the cross-sectional imaging, then you can see it much better here. You can clearly see a flap in the basilar artery in this area. Again, a flap here. And we know this was dissection. Dissections can involve multiple vessels at the same time. For example, this patient has subarachnoid hemorrhage due to interclinic dissecting aneurysm. But at the same time, you can see the right vertebral was dissected. The ICA was also dissected. So multiple dissections are pretty well known. And one should be very careful in doing DSA in these patients because you may cause further dissection during the procedure. This is another patient with right-sided ischemic symptoms. But when you do a DSA, what we realize that there's a classical dissection. There's a narrowed artery, then dilated. So this was a dissection with a small aneurysm formation in this patient. And interestingly, even on the opposite side, there was a dissecting, opposite cerebral artery was also dissected with a fusiform aneurysm in these patients. So you have to realize a lot of interclinic dissecting aneurysm initially can present with ischemia, but later on may develop big aneurysms and may cause bleeding as well. Like this was very interesting, young man with the anterior coronary artery infarct. This was thought to be a ring enhancing lesion and the true pathology was missed. Whenever you see a too funny lesion, you may think whether it's a vascular pathology which has caused infarction here. And on follow-up, we can clearly see like a clot here in the choroidal fissure. And when we did the DSA, this is again a 3D vaso-CT image. This is the choroidal artery. There was a dissecting aneurysm of choroidal artery, which is here, and which has caused this choroidal artery infarction initially. So a lot of interclinic dissection may cause initially ischemia, and they may develop aneurysm, and you don't detect at the right stage, these aneurysm may rupture and cause massive hemorrhage in these patients. From dissections coming to vasculitis. Now vasculitis is a very big topic, so I'll just show you a few slides, how do we handle it. So large vessel vasculitis is often detected by even MRI or CTA because they show up the major vessel disease pretty well. Medium vessel vasculitis in this dedicated cerebral DSA shows up pretty well. But you have to realize that small vessel vasculitis will be missed on any CTA or a DSA, and a lot of these patients are diagnosed on histopathology and correlation with a lot of information. So vasculitis is just not DSA diagnosis. So there has to be clinical lab workup, MRI, DSA, and in some cases biopsy to be sure that this is a case of vasculitis. So signs can be subtle, like in this MRA, one can see multiple small areas of narrowing here and there. So until one is actively looking for these narrowings, these findings can easily be missed. Same thing on DSA. Not a great quality image, but you can see some narrowing and then dilatation, some narrowing here, some irregularity here, some irregularity here as well. So you have to look at these images, you have to do high resolution DSA and look for very subtle signs, look at these images carefully. So in this patient, of course, the medium level vessels are involved. So what are the classical findings of vasculitis? Angiographic findings, segmental stenosis and dilatation in multiple vascular teratitis is classical. There are many subtle signs as well, such as mass effect, delayed transit time, neovascularization. Sometimes there can be early venous filling, microaneurysms, attenuation of distal branches have been reported. Now, there's a classification which has been, grading system which has been proposed. So whenever you see vascular bleeding or alternate area of stenosis and ectasia in multiple vessels, is high probability. When you see such findings only in single vessels, medium probability. But when you see only mass effect or one isolated stenosis, then it's a low probability. And why this is important is because vasculitis-like findings can occur in other diseases as well. So as I mentioned, sometimes you may not see anything on DSA. This patient has these infarctions. But in this case, you can see this is the major vessel involvement. And as I said, these findings can overlap with many other diseases. And in this case, I will discuss more in detail. We did vessel wall imaging, and it showed a concentric enhancing thick walls. And this was very diagnostic of vasculitis. So not only the DSA, other imaging, cross-section imaging also becomes pretty important in these patients. But when it seems to small vessel involvement, as I have discussed, in these cases, cortex, subcortical, basal ganglia can be involved. It can be associated with leptomeningeal dural enhancement, and there can be a lot of microhemorrhages, maybe the symptoms, which may give you a clue in this patient, while angiography may be normal. So like this patient with basal ganglia infarction, and what you can see some subtle changes in elsewhere in the brain as well. But when we did SWI imaging, you can see multiple microhemorrhages. The DSA was normal, but multiple microhemorrhages, it tells you that small arteries and venues are involved, and this is probable vasculitis patient. So as I mentioned, the vasculitis findings of constriction and bleeding are not very specific. They can happen in many other disorders. Sometimes I will show you RCVS and vasospasm and other problems. Even infections can lead to vasculitis like picture. Now coming to moyamoya, which is a separate disease, a classical, it happens usually present in young patients with ischemic symptoms like this patient. And you can see multiple areas of infarction on MR. And when you do a DSA in this patient, the multiple DDs when you think about, and the MR findings sometimes are diagnostic, but you can see that there is probably a lot of small vessels which are dilated in basal, in the subarachnoid space and basal ganglia, which is very diagnostic. And the major vessels you can see here, you can see it very well. This is a normal patient, and this patient, you cannot see major vessels. A lot of small vessels are seen. So MR itself, you can suspect moyamoya vessel disease. And when you do the angiogram, this is classical. And a lot of perforator collateralization and even dural collateralization is present in this patient. This is classical of moyamoya. So moyamoya is an occlusive form of vasculopathy. There's a progressive stenosis of terminal IC and proximal MC and ACA. And there's a compensatory proliferation of basal perforator vessels, which give rise to this moyamoya, which is Japanese word of puff of smoke appearance. And these collaterals, they go through thalamus and basal ganglia to provide collateral flow. Young patient present with ischemia, whereas adult patients usually present with more commonly with hemorrhage in these patients. So I'll not go into the details. This is Suzuki classification grading system, grade 1 to grade 6. How initially you develop moyamoya symptoms, the major vessel disappears, and then even the moyamoya vessel disappears and the external carotid artery takes it over, and that is how they grade it. And nowadays there is even a MRA grading system which is available to grade these patients. So the collaterals are seen as cloud of smoke or puff of cigarette smoke, that is given it to the name. It is widening of the existing vessels or new perforating arteries, and the branches may come from ICA, PC, or anterior carotid artery, and they may combine distally with the distal midseval artery to provide collateral flow. So collateral flow can be through parenchymal, meningeal, as well as transdural. So just to show you some typical pictures, this is periventricular anastomosis from lenticular. These are MC is gone, but the lenticular striate artery is hypertrophied, and periventricular anastomosis then retrogradely through the transmedullary. And here you can see, again, if you see carefully on the MRA, one can see them as well. And as well as in this vessel imaging of MRA, one can see this collateral very well. So if you look for them on MRA is not so easy to see all the collaterals, one can see. And this is a classical trans from lenticular striate through the periventricular. You can see retrograde filling of the cortex. So even thalamotuberal artery in this patient, again, give rise to collaterals. And again, you can see it here and going around, and one can see a small aneurysmal involvement or a microbleed here as well. So because these collateral under pressure, they can rupture and cause microhemorrhages. This is thalamo-geniculate artery collateral, again going through the parenchyma and giving rise to collateralization, and you can see that on the MRA as well. While anterior carotid artery is also one of the common routes in this patient. So this is a hypertrophied anterior carotid artery, which is giving rise to a lot of collaterals. And again, one can see some small microhemorrhages and hemorrhages because this collateral with age, they get damaged, they develop aneurysmal changes and cause hemorrhages as well. So while DSA remains the gold standard, MRA is also can be pretty good, particularly when, as I showed, you have to do MIP images, you have to sit on the console and see them very carefully, then one can see a lot of findings on MRA, but of course, small collaterals can still be missed on MR angiography. A lot of surgeons, they like to get some kind of perfusion imaging, and ASL is one of the method which has been used for looking at, this is a non-contrast, non-invasive way of looking at perfusion imaging. in these patients. Now, I mentioned aneurysmal formation. Now, this is also pretty important. So a lot of patients in adult stage, they present with aneurysmal bleeding in these patients. So aneurysmal changes can be peripheral aneurysms caused by the collaterals, or because posterior circulation, a lot of hemodynamic pressure, because at initial stages, PCA give light to collateral, they can develop saccular images at the circle of Willis. Like this is one of my old AIMS patient presents with subarachnoid hemorrhage, classical moyamoya, a lot of leptomeningeal and dural collaterals in this patient. And here, posterior cerebral artery was giving rise to collaterals and had developed an aneurysm there, which we had to coil. Another patient with small bleed here with interventricular extension, again a moyamoya-like pattern. And on the collateral distally, what you can see, there's an aneurysmal change here in one of the choroidal artery collaterals. Now here on the 3D images, you can see it very well, hypertrophic choroidal artery. And this had bled in these patients. So once you can diagnose, a lot of these patients, we could access, and here we could glue this artery as well. There are some other disease which may mimic vasculitis or other internal diseases. Like this patient had a sudden onset severe headache as well as weakness, small infarction was seen, a lot of vascular narrowing, and DDs can be vasculitis, vasospasm, moyamoya, or RCVS. But all the initial angiographic picture were like this. Within 2 weeks, the arteries were back to normal. So this is classical of a disease known as reversible cerebral vasoconstrictive syndrome. And one should be aware that sometimes in acute stage, it may mimic a lot of diseases, and the reversibility and other clinical features tell us this is RCVS. It doesn't mean we always look at radiology neurology intracranial vessels. One should be aware when you're doing imaging to look at the chest as well. Like in this patient with TIA, MRA, initial brain was not fine, but when you look at the aorta carefully, there was a dissecting aneurysm of the ascending aorta in this patient. So whenever we are looking images, one should look at and it was extending here into brachiocephalic as well. And this is an important diagnosis which cannot be missed. The last part, was about differential diagnosis, stages, and how we use imaging for stroke. The last part, in short, I will talk about vessel wall MRI, which is a very exciting and a new, not a so new field, but we are doing it more and more in our patients. So vessel MRI, we do very high resolution, 0.4 millimeter voxel size MRI, and we look at the integral vessel wall, that how the vessel wall is in these patients. So we'll usually do something like this, T1 in cornel. You can see this is the ICA, and you look at the vessel wall here, and the same thing we look in the axials, in middle cerebral artery and other vessels, and sagittal as well. These are very high resolution, thin section, better obtained on 3T MRI. And we do fat suppressed T2 as well to look at T2 signal changes in the vessel wall, and followed by post contrast to look for any enhancement in the vessel wall as well. And it's pretty useful. So for example, they have found that for non-occlusive internal vasculopathies, the correct diagnosis gets better by 36%. It improves to around 90% or so when you do vessel wall imaging in intracranial vascular diseases. This was one study published from Korea in which they found when the age is less than 55, when there was minimal risk factors for atherosclerosis, when you do vessel wall imaging for a stenosis which was presumed to be atherosclerotic, only 27% had findings which were like atherosclerosis. Other diagnoses were different. So it can change the diagnosis of a lot of patients, and particularly more in the Asian population where other diseases are more common. So what are the findings? So you have to realize it is mainly you should distinguish between moyamoya, vasculitis, RCVS, and atherosclerosis. And this shows a cross-section of how different histopathology is, and which we can see when we do high resolution vessel wall imaging. So in moyamoya, the arterial size decreases, the intima thickens a lot, and the media becomes thinner, and the lumen is narrow, but the arteries become much thicker and it doesn't enhance. While in vasculitis, the wall becomes overall, all the section of the wall becomes much thicker, and lumen becomes narrowed, and because there's a lot of inflammation, it tends to enhances diffusely as well. While RCVS, as I discussed, also angiographically may mimic vasculitis, but once you do vessel wall imaging, because the lumen is narrowed in these cases, but it merely is the constricted media, and there is no inflammation. That means there will be no enhancement as compared to vasculitis. Well, we'll come to atherosclerosis. The lumen is variable. I will discuss how atherosclerosis may cause luminal remodeling. Usually it is eccentric in nature, and there can be inflammation in the plaque as well. So coming to intracranial atherosclerosis and how vessel wall images helps us to diagnose it. It sees remodeling pattern. It looks at the various plaque, how is it involving the artery, and enhancement pattern as well. Now, what is remodeling? Now, when atherosclerosis can happen, one can have positive remodeling. That means the arterial diameter may become bigger, and is tolerating a lot of plaque with minimal nummular narrowing. So once you measure the arterial diameter at that level versus proximal, and you see is more than 1.05, there's a positive remodeling, and in these cases there can be a lot of plaque burden, while luminal narrowing may be very minimal and you may miss it. While negative remodeling, when the whole arterial diameter actually may reduce, the plaque burden may not be as much as positive remodeling, but there will be much more severe narrowing of the artery. And this is what we can all diagnose by vessel wall imaging. For example, a case like this, in middle cerebral artery stenosis, when you do vessel wall imaging, this is normal. This is this particular patient. What we can see, the whole diameter of the artery is reduced, and this is the plaque which has caused narrowing. So this is known as negative remodeling by atherosclerotic plaque. While something like this, you may say, oh, the artery is dilated, but actually when you do vessel wall imaging, you can see a big plaque here in the vessel wall, because in this case, as compared to normal, there is positive remodeling. That means the arterial diameter has become much bigger. Lumen is quite preserved, but there's a huge amount of plaque burden in such a patient. This is known as positive remodeling. And this is clinically very important because number one, you can diagnose even when the arterial lumen looks normal. And you may think why the patient is having strokes. From cryptogenic strokes, you can actually see is because of ICAT, because the plaque can be seen on vessel wall imaging, which was missed on CTA, MRA, or a DSA. Also, the remodeling type tells you the risk of stroke, because whenever there's positive remodeling, there is more chance of intraparenchymal hemorrhage, inflammation, microembolism, and these are high-risk plaques. So positive remodeling, when the lumen may not be narrow, but there's a lot of plaque burden, and these are high-risk plaques. We can also see which part, this is middle cerebral artery we are cutting in cross section, which part of middle cerebral artery is involved, and that will also tell us what is the risk of stroke in such a patient. In asymptomatic patients, it is mainly ventral and inferior walls which are involved. In yellow, we can see that. While in symptomatic patients, the superior wall is more common because, of course, perforators are coming from here. So there's more chance of superior wall involvement. So whenever you see a superior plaque, you know is more likely to be symptomatic in these patients. So just to summarize, 2/3 of the strokes are actually because of positive remodeling, high-risk plaque which causes plaque rupture, while only 1/3 are because there is a stenosis that said negative remodeling, in which there is an endothelial injury and thrombus formation, but no plaque rupture in these patients. So how do plaques look like, and how do we study plaque architecture on vessel wall MRI? So this is the classical one. Here you can see this is the lumen. This is the fibrous cap. So if you see, this is the dark thing is the lumen. This brighter thing, not too bright, is the fibrous cap. And this is the fatty core in this patient. And this is the adventitia media. So we can see this is the plaque with the preserved fibrous cap in this patient. While there's another patient like this, this is the lumen, but you can see the fibrous cap seems to be broken in between, like a gap. So we know this is a ruptured plaque in this particular patient. And lumen, fibrous cap, the plaque. In this case, the lumen, fibrous cap is broken, and then there is the plaque is there, and then this can really embolize. This is a ruptured plaque. So by these kind of imaging, by T2 and T1 combined, we can study the fibrous cap, amount of plaque burden, as well as the fibrous cap is preserved or not. The enhancement in atherosclerosis can be a lumpy enhancement, but it is almost always eccentric enhancement in this patient. Also, we can see intraplaque hemorrhage by vessel wall MRI, like this patient with a stroke, middle cerebral artery stenosis. Here you can see this is the T1, T2 sequence. This is the eccentric plaque, but on T1 it is very bright. T2, T1 very bright. They show there is an intraplaque hemorrhage in this patient, and intraplaque hemorrhage means it's more likely to be symptomatic and more likely to become symptomatic in future as well. The contrast enhancement degree in atherosclerotic plaque in vessel wall MRI can also tell us how risky the plaque is. For example, this case, you can see not a very severe stenosis, and there is plaque, but not too much of enhancement, while in this case, there is very severe enhancement of the plaque. So whenever the enhancement is very severe, then we know vertical is grade 2 enhancement, then we know this is likely to be the culprit lesion and may cause more strokes in future as well. So just to summarize about atherosclerosis and vessel wall MRI, we can see these are eccentric plaque, we can see T2 heterogeneity, and through T2 we can see the fibrous cap, we can see look for the remodeling, and we know whenever there is a positive remodeling, then there's a high plaque burden and higher risk of stroke. I haven't discussed about walls, and we have seen by site of plaque, we can discuss the risk of stroke. High-risk plaque features include having a lipid core, intraparenchymal hemorrhage, and grade of enhancement, and this enhancement remains for 4 weeks. So sometimes there's a confusion with vasculitis. After 4 weeks, the plaque usually stops enhancing, but the vasculitis, the contrast enhancement remains for a long while. Coming to vasculitis, as I discussed, usually it is smooth concentric wall enhancement with thickening in these patients. Like this is a patient, some irregularity here, and this is the cross-section T1 weighted, but post-contrast, you can see diffuse thickened enhancement of basilar artery, diffuse thickened enhancement of posterior artery. These are very diagnostic of vasculitis in these patients. So in vasculitis, as I mentioned, the enhancement can remain for a much longer while, up to 7 months or more as well. And sometimes the enhancement may be in single vessel or multiple vessel, or it may also extend beyond the vessel wall into the adjacent periadventitial tissue because of the inflammation. Disease activity, some people have tried to use vessel wall MRI, whether the enhancement disappearance means disease has become inactive, but sadly the evidence says that we are not sure about this. But definitely the vessel wall enhancement can be used to target the biopsy site. So as a neurologist, if you know you have to get a biopsy and not to have negative biopsy, so this is a very small study in which they used the transmural inflammation as a site to diagnose, and then the biopsy positivity rate was around 90% or so, which we know otherwise is pretty low, from 36 to 64% in just random biopsy, while in this small study, when they use vessel wall imaging and inflammation detection for biopsy, the chances of positivity was much, much higher. We have discovered RCVS, vasoconstriction syndrome. In these cases, what happens, the media becomes much thickened, but there is not much inflammation in these patients. That means the arterial wall, like this is the pre and post contrast images. So what we can see, there is no enhancement, although the arterial wall is thick. One can see the arterial wall is thick, but there is no enhancement in these patients. And on follow-up, it resolves by itself. But while in vasculitis, this would have been densely enhancing, and in follow-up would have remained so as well. It doesn't resolve by itself. So if you have to compare between ICAD, vasculitis, and RCVS, T2 hyperintensity in ICAD can be presented in the plaque, while it's absent in vasculitis and absent in RCVS. While T1 wall thickness is eccentric in ICAD, while in vasculitis it is circumferential, and in RCVS it is usually circumferential, sometimes can be absent. The contrast enhancement can be grade 1 or grade 2 in ICAD. When vasculitis is always dense enhancement, while RCVS usually they don't enhance. And contrast enhancement pattern can be heterogeneous, diffuse to heterogeneous to focal, while vasculitis is always diffuse enhancement, and RCVS is rare to enhance, but if it enhances diffusely. Now coming to the last part about moyamoya disease, as we discussed from the histopathology, here the vessel negative remodeling is there, the vessel wall thickness slightly more thickened, and the lumen is narrowed, and usually there is not much inflammation going on there, which helps us to diagnose this patient. As I mentioned, the outer diameter progressively decreases, while this doesn't happen in other diseases such as vasculitis, ICAD, or RCVS. So again, moyamoya as compared to atherosclerosis, the outer diameter is less than atherosclerosis. Like in this patient, the vessel wall, overall vessel size has become smaller than the normal, and wall thickness is maintained, and sometimes, but it can be much more in atherosclerosis, focal wall thickening, and homogeneous signal is there, while in atherosclerosis there will be more heterogeneous signal. We discussed because of the plaque, the fibrous cap, and the fat, and the hemorrhage. So these all features can be used to differentiate between moyamoya and other disorders as well. So just one slide showing how some people are beginning to use vessel wall imaging in aneurysms. Like this patient, subrectal hemorrhage, there are 2 PCOMs aneurysm. You don't know which has ruptured. So vessel wall enhancement can happen in ruptured or symptomatic aneurysm, thick vessel wall enhancement. And this was very suggested that this is a ruptured aneurysm. So although we need more data to be clear about the decision making. Some of the artifacts which can happen. So after thrombectomy, if you do, like in this patient, the clot was taken out, if you do vessel wall imaging, sometimes there can be enhancement because of endothelial damage. So one should not regard this as vasculitis in this kind of situation. Some other artifacts which can happen, slow flow on T1 look like plaque, but when you do contrast enhancement, there was no plaque. And sometimes the small veins along the arteries can also look like enhancement. You should be careful about it. So just to show you one of these recent cases, This was 37-year-old doctor with some small ischemic lesion, middle cerebral artery stenosis. You wonder whether this is atherosclerosis or not, what is really happening. But when we did vessel wall MRI, you can see eccentric involvement of the vessel wall, and post contrast, there's eccentric enhancement. This shows that this is not vasculitis or dissection or CVS. This is atherosclerosis in this patient. This patient I've shown before, diffuse integral narrowing involving the again, we don't know what the diagnosis is, but when we do vessel wall imaging, diffuse thick enhancement in all the planes, we can see very, very clearly, which is very suggestive of vasculitis, and then one can treat accordingly. So just to conclude my talk, imaging plays a very critical role in diagnosis and management of stroke. Acute stroke imaging has to be protocol based according to your institution capability, but has to be done very fast. Vascular imaging, as I discussed, CTA, MRA, and DSA have their own roles, but the interpretation, as I tried to put it out in my talk, should be clinical oriented. Vessel wall imaging is emerging as a very critical in integral disease diagnosis, particularly in young patients, to look for all the differential diagnosis. And I want to thank you on behalf of Artemis Agrim Stroke and Neurointervention Technique, my co-faculty, Dr. Raj Nivas, who is attending the meeting, Dr. Nishchindan, and our clinical associate consultant and fellows as well. And I want to invite you all. Our neurocritical care unit, our department, is conducting this online meeting on neurocritical care and collaboration, Neurocritical Society of India and CSI virtual. Why I'm mentioning here is it has also got TCD workshop, which is again vascular imaging, which I haven't touched because of lack of time in this today's talk. But if you're interested in transcranial Doppler, you can attend this meeting, and there is a complete workshop being conducted, one of the foremost authorities in the world, how to use transcranial Doppler and this kind of vascular imaging for stroke patients. Thank you. So I will now stop sharing, and we can now maybe activate our mics, and if there are any questions, we can always discuss them.
Yes, sir. You hear me, sir?
Yes, I can hear you. Yes.
Okay, thank you, sir, for your
Okay, I was muted. Sorry. Yeah.
Yes,
Yeah.
sorry, sir.
I can hear you.
Okay, thank you, sir. Thank you, our keynote speakers. I think we have learned many things and many new imaging technique for diagnosis and management, which help our clinical practice and also patient care. If you have any question, please write in your question box. Then I collect it and transfer to our keynote speakers. Now I welcome, sir.
Yeah, Dr. Subhash.
Yes, sir. Sir, most welcome, sir. Our Din Mohammed sir is now here. Most welcome.
I enjoy whole of the topic lecture. Can you hear me?
Yes, sir.
We can hear you.
Yes, sir, audible. Dr. Bipul, I must thank you. I have sincere thanks for you for wonderful speech in detail for vascular imaging in stroke. I have two questions.
Yeah, please.
First of all, is it that DSA should be a routine investigation in all ischemic stroke? This is number one. Do you think that DSA should be a routine investigation?
Yes, sir.
In all ischemic stroke?
So
this is number one question. Number two, when you decide not to, did you get my question?
No, not the second one. I couldn't get it, sir.
The second one, when do you decide not to intervene the major vascular occlusion?
Okay. So the first question is easier to answer. DSA we don't do as a routine. Initially, we always do a non-invasive imaging like CTA and MRA. In older patients, that is enough usually to exclude any stenosis. And if you have doubt, we may do vessel wall MRI in some patients. But when we have an intercranial stenosis in older patients and we are not sure about the degree, then we do a DSA. Number one. In younger patients, in young strokes, we do like to do DSA because then you look for vasculitis, subtle signs, and intercranial vessel involvement. So that is better seen in DSA. But most patients, initially it has to be non-invasive, and in older patients in atherosclerotic, usually non-invasive is enough. Unless and until we see something and we need to study it further, then only we do a DSA in those patients. Okay. Now, secondly, in occluded artery, when not to intervene, so we can divide this into two: in acute stroke situation or in non-acute stage. In acute stroke, if the patient is clinically intact, it clinically have very mild symptoms, that means collaterals have taken over, then we don't like to intervene, but we have to observe them very carefully because some of them may develop symptoms in next few hours, and then we like to intervene. In terms of carotid stenosis treatment in subacute stage, once the acute stage is gone, if the IC is completely occluded, then we don't intervene and we don't do carotid stenting because trying to do stenting in those patients may cause more harm than good. So completely occluded artery, we only intervene in acute stage, not in subacute stage usually. So I hope this has answered your query. I mean,
I have got another query. Do you think that so we should go for CTA initially or MRI angiogram initially, then we can go for the DSA, right?
yes, absolutely. CT angiogram is
Absolutely.
what we like, but MR angiography is also
Okay.
good. Yes.
Okay. Second thing, that do you think that only the vascular occlusion or any other clinical parameters are also very important in case of decision regarding intervention or not intervention? Because if there is, say, about 85% IC occlusion, this is 3-4, will you go for intervention?
So 85% stenosis, if patient is symptomatic, then definitely. If it is asymptomatic, then a lot of these patients can still be handled medically.
GCS is 3-4 or 4-5.
GCS is 4-5 and IC 85%, there is no point. I mean, clinical is very important. So IC, carotid stenting is only done when patient is clinically independent. If suppose patient has got large middle cerebral artery infarction, patient is bedbound, completely paralytic, then there is no point trying to stent that artery. We don't do stenting.
Exactly.
In those patients, if they recover, they become independent, then only we do stenting.
Okay, that means you also consider few other aspects of clinical parameters.
Absolutely.
Along with the degree of occlusion, right? Like
Absolutely.
GCS, the degree of paralysis, the in general condition of the patient. So then you decide. Okay.
Absolutely, absolutely, sir.
Okay. It is not all at the time frame or degree of stenosis. It should be correlated with the other clinical findings. Okay.
Absolutely.
Thank you very much.
Thanks.
Can I ask one question, Subhash?
Yes.
Can I ask one question?
Yes, sir. Of course, sir.
Okay. To Vipul,
yes, sir.
thanks for your beautiful presentation. I think it's difficult to digest in one go if you try to cover everything.
That's quite a lot. Yes.
I will come to that later on, but I have a question. What you mentioned about in vasculitis, that microbleeds and the beaded appearance and etc. in MRA or DSA. But I wonder what would be the difference in MRA or MRI in case of CAA from primary CNS vasculitis. You have got my point.
So,
I mean, amyloid angiopathy, that's also microbleed or lobar bleed, or sometimes they also show microbleeds. And how to radiologically differentiate between these two, primary CNS vasculitis.
So most important is actually clinical, because usually some cerebral amyloid angiopathy will be presenting in older patients.
Yeah.
So clinical becomes very, very important here.
Point. Good.
And as I mentioned, all the other lab tests becomes very important. CSF findings, other findings. Number two, radiologically, usually in vasculitis, we'll see patchy infarctions in multiple territories and multiple very small bleeds. Well, usually amyloid angiopathy, 1 or 2 areas of bigger bleed may be there. Maybe other microbleeds. So here the clinical other lab tests as well as radiologically, and then we try to make, but most important is clinical, because usually there will be in older patients, and this patient will be younger set of patients, and that becomes very, very important. But as I mentioned, vasculitis can be a big enigma. It can be a lot of very challenging to diagnose. Again, because I was trying to cover so much in such a short time, I went over
Yeah,
it
I
quickly.
understand.
It's a separate
Yeah.
topic of its own. There's a whole talk can be on just vasculitis imaging. But I just try to lay it out that major vessel, medium vessel, small vessel. And in small vessel, biopsy makes the final diagnosis in vasculitis in many cases. Yeah.
Thank you.
Thank you, sir. One question to Vipul sir from Dr. Amir Hussain. Is it
Yes.
necessary to use contrast in vessel wall imaging always? And what are the findings in vessel wall imaging in ruptured aneurysm in subarachnoid hemorrhage? I think second question already answered.
Yes.
You shown,
So,
but about the first questions.
So contrast enhancement is very important because, as I discussed, in vasculitis, you will see concentric enhancement, while in atherosclerosis, usually we'll see eccentric enhancement, while in RCVS and this moyamoya, we will not see much enhancement. So enhancement is very important in trying to differentiate. So we almost always do with contrast vessel wall imaging. Yes.
Okay, thank you, sir.
Yes.
Now I welcome Dr. Shahriyan Nobi. Is working as a associate professor of neuroradiology and as general secretary of our Radiology and Imaging Society. I ask Shahriyan Nobi to tell something about today's topics and presentation.
Thank you, Dr. Subhash, for allowing me to give some speech. First of all, I thank Bangladesh Society of Neurointervention to invite Bangladesh Society of Radiology and Imaging as a co-host for this webinar. It is no doubt a great new era for the development of the two society. Before going to panel discussion, I give my heartiest tribute to the frontline health workers who lost their life against COVID-19 pandemic all over the world. Now I give my great respect to the honorable guest, Professor Kaji Din Mohammed, Director, National Institute of Neuroscience, and he is also my mentor and inspiration. I always get a lot of support from Professor Kaji Din Mohammed sir. I feel honored to say something in front of me. I also give my respect to another honorable guest, Professor Kaji Firoz Ahmed Qureshi sir, the President, Bangladesh Society of Neurologists. Now I thanks Dr. Bipul Gupta, the Chief Neurointervention Surgeon and Stroke Unit at Metis Hospital, India, to choose these interesting topics for this presentation and this webinar. The early diagnosis and treatment is the very challenging part for the physician. Especially in our country, we commonly use CT, MRI, CTA, MRA, and MRV. Nowadays, this is a significant tool, but you already discussed about what type of BSA, what kind of BSA, how we'll go the procedure. Is a nice presentation. You already delivered it in your speech. But in Bangladesh, every modalities we are trying to develop. But the one thing I'll say, every modalities have a advantage, some disadvantage for the diagnosis. But during our imaging procedure, we will face a lot of confusion, especially vasculitis, pleural plaque. You already mentioned the vasculitis is a very big and vast chapter. Within this 1 hour, it is very difficult to brief. But in a short period, the way you present it is nice. I think that the radiologists and neurologists, those who are in front of this webinar, they will inform a lot of things they basically collect from this webinar. The imaging is basically going on very fast, just like the more than COVID-19 pandemic. COVID-19 pandemic, within 3 months, a lot of disaster is going on in the world, but imaging procedure, imaging tools are going faster than COVID, I think that. And again, I thank Dr. Bipul Gupta for your nice presentation. And thanks again, and hope all the participants, they will take good message from this webinar and have a take now sound sleep and without any tension that the diagnosis of this vascular disease. Thank you all. Thank you.
Thank you.
Thank you. Thank you, Sharinabi Shakil Bhai. Now I request Professor Firuz Ahmed Quraishi sir, the President of the Society of Neurologists of Bangladesh, to discuss something about today's webinar.
Am I audible now?
Yes, sir.
Yes.
Yes. Thanks all the participants first for the nice active participation. And I must thank Professor Vipul Gupta for his nice and fantastic deliberation. It's a very nice one. He has just presented the whole of the intervention neurology, a big chapter in intervention neurology, in a small box to us within a 1 hour to 1 hour and 15 minutes time. So it's a very credit, and the credit, all credit goes to you, the honorable speaker. I have nothing to say, especially he has covered all the stones, and he has also covered the advantages, disadvantages of the vascular imaging, CT, CTA, MRI, MRA, and also the lumen and vessel wall imaging in DSA and other modalities. So I think he has left nothing to say to the panelists. Thanks again. And I once again from the Society of the Neurologists of Bangladesh has a keen invitation for him when the corona situation just normalize, and we host you. Thank you very much. Thanks all the participants.
Thank you, sir. Pleasure.
Thank you.
Thank you.
Thank you,
Thank
Firuz
you very
sir.
much.
Now I welcome Professor Qazi Din Mohammed sir. He is well known to all of us, and he is a teacher of the teachers. So most welcome, sir. Sir, Professor Din Mohammed sir.
Okay, thank you, Dr. Shubhas. First of all, I would like to extend my sincere thanks to Dr. Vipul Gupta for his wonderful and very elaborative description on vascular imaging in stroke. I think we can clearly see his expertise through his deliberation, how he delivered the whole picture of vascular imaging in stroke. This actually reflects his knowledge, reflects his skill, reflects his innovation and dedication. So we learn a lot, and we have got quite a good number of take-home messages from your deliberation. And I think we as a neurologist, particularly our young neurologists, those who are interested in practicing interventional neurology stroke in this country, will be highly benefited. And on the table, I would like to thank Dr. Gupta for another reason, that you have trained a few doctors from my country, and they are now working with full confidence and going ahead with the chapter of neurointervention in this country. What I can say that a decade before, we didn't have any idea about intervention. But because of our colleagues from India, Dr. Gupta, Dr. What is his name? Other fellow, Shakir Hussain, and these two people actually instigated our young neurologists to be trained in neurointervention from India. And they have trained from India. Now we have a small group who are actually practicing these kinds of neurointervention in my country. And as a result, the patients are getting benefit. And we all feel that vascular imaging is a very integral part of acute stroke diagnosis and even intervention and management. That has really improved the outcome of acute stroke recently, that what the outcome in the past. So gradually these chapters get interest, and many neurologists are being attracted from their point of view to be trained in intervention. So in NIMS, as you know, that we have got a very good cath lab, and we have got a very good team. Those are working. And in the university, Bangabandhu Sheikh Mujibur University, they also have a good team, and they are now building a a very wonderful and update cath lab in the university. And you'll be happy to know that we have got a recent installation of cath lab in Dhaka Medical College. So you see how we are progressing day by day. And this is because of you people that you actually inspired our young neurologists so that they can be working in this field. So in that sense, I think we are very grateful to you, and we sincerely thank you for keeping with us and keeping us with you, and all the time keeping in touch with young neurologists and boosting them up and developing the chapter in this country. And I sincerely thank you again for your for your collaboration and wonderful speech, the master speech in neurointervention. So I thank the Society of Neurologists. I thank Professor Shakir, who is the very academic radiologist in this country, and I thank the interventional staffs in my country for organizing this wonderful virtual symposia that is ever remembering. Thanks a lot. Stay home and stay safe. Thanks everybody.
Thank you. Thanks a lot.
Thanks, Professor Din Mohammad sir. Now I request our professors, Professor Anisulok sir, to tell something about topics and management.
Thank you very much. All of you are my students, and then students after students, grand students anyway. I'm happy that you have come to this much when we started long ago. And you have now 2, 3, third, fourth generation of interventionists. You are one of the first generations. Couple of first generation, Sakir and Bipul helped. And now we are having lots more, and daily we're developing. But I just want to mention a couple of things as a senior neurologist, because I don't have continuous interaction with you. Rarely I get chance to suggest you what you need to do, which I used to do regularly in the past. So this time I would say, look, I would be happy if I can say that we have many clinical neurologists, we have many clinical professors, we have interventionists we can be proud of. But I want to be proud of with some of the neuroradiologists. Okay, I don't understand if I fail to make it clear to everybody that neuroradiology, without a neuroradiology or a neuroradiologist, a neurologist cannot survive. I have learned this from my NHS experience, that it's very important that every center should have a neuroradiologist. Today's lecture, it's very important. It covered everything, not only for the interventionist, it is for all neurologists. There is lots of things to be learned. So all neurologists, training any neurologist should be trained with the neuroradiology at least for a month or so, especially in the good neuroradiology center. It is very important because in NHS anyway, we have some limitation. If some neurologist just suggest I need a MRI, even he cannot say anything, the clinical details, though they can have some clinical detail, the neuroradiologist has the freedom to do whatever they want to do to come to a diagnosis, or he will phone the neurologist that I think this is this and that and that. So I want to do that. And then they discuss. And every time a neurologist have any trouble, they take the film or the CD, or nowadays we don't need any film or anything. You go straight and discuss with the radiologist what you think can be. So again, I tell you, try to focus on this, that try to have a good neuroradiology center or some famous, I want to have some famous neuroradiologist in Bangladesh in a year. Second is, I would just to the junior doctors, junior neurologists, there are 100 plus participants today that rightly people have mentioned that a simple thing is missed, which is not uncommon, is carotid artery dissection. You have to be very, very, mindful, not missing this. It's not always clear. You're not always the honor or incomplete honor, or you may get a trivial minor focal lesion, but if the patient has got an neck trauma, commonest problem is in the barber's chair, or sometimes they manipulate the neck in our country, and they suddenly manipulate, and that can cause some form of numbness, weakness, etc. And also you will not see any focal lesion in the initial state. So lots of things, the neck pain and the cranial nerving, cranial vein involvement, etc. You should keep it in mind that this should not be missed. Very, very important, he pointed out. And third, I would say, initially I said it is impossible to keep, or it's like in a Bengali or some culture that all food on the plate at the same time. It is not possible to digest everything. So if you really want to use Bipul's expertise, ask him again, one lecture, one thing, and not only for the interventionist, because I understand not all 100 plus participants are interventionists, others will be benefited. So also, I would request the interventionist club, interventionist society, to please organize, take help of people to give lecture, regular course or master class or something for all the neurologists in Bangladesh to understand little bit of neuroradiology, because it is important, because they work alone in the periphery and you can't suggest everything, because you ask for DSA, you ask for anything, they will charge. Even for every suggestion, they will charge extra, which is sometimes difficult for the patient. So, and this has to be sorted out, how to solve this as well. And thank you very much, Dr. Vipul, and also the organizer, and also my friend Bin Mohammed, my student Firoz, and everybody who are working hard to raise the position of neurointervention in Bangladesh. Thank you very much.
Thank you.
Thanks, Anisulok sir. Now I welcome and request Professor Kazi Mohibur Rahman to give vote of thanks. Kazi Mohibur Rahman, Secretary General of Bangladesh Society of Neurointervention. Mohibur bhai is here.
Thank you, sir, for your very elaborative lecture, and we will hope that we will see you in Bangladesh next time. Thank you, everybody, for participating. Thank you all.
It will be a pleasure to be there.
Yes, thank you, Mohibur bhai. And now I welcome Professor Sharifuddin Ahmed.
Sharifuddin Khan.
Sharifuddin Khan to deliver his speech as chairperson and conclude today's discussion.
Thank you, Dr. Subhash. Can everybody hear me?
Yes.
Thank you, my respected teachers, Professor Anisulok sir, Professor Kajiddin Mohammad sir, and Professor Firoz Ahmed Qureshi sir, Professor Khokon Kanti sir, my senior colleagues, junior colleagues, and all the senior and junior members of the different society. Today is I should say, is a historic day, because with the neurologists, neurointerventionists, and as well as radiologists came together in a common forum to discuss about the current and burning topic of today's session. Today's webinar, the keynote speaker was Professor Bipul sir, who is very much familiar, not only in India, all over the world, he is very familiar. So he touched every topic regarding acute stroke imaging, starting from the very basic of CT scan, MRI, and ultimately we went to the vessel wall imaging and in details, in-depth analysis of vessel wall imaging, considering the different etiology and diagnostic tools of the disease. And we became very much helpful, and it was tremendous that we have to cover up everything. And I personally became very much benefited knowing that sometimes source imaging and perfusion imaging that will also help our young neurologists whenever they are planning to go for any intravenous thrombolysis or understanding of the basic lesion of the acute stroke. And I must thank Professor Shakil, Shahriyan Nabi Shakil, who is the Dean of Medicine Faculty, Dhaka University, along with his society, all the senior and junior members, and all the supporting team, those who supported us. And I must thank Dr. Shiraji, who actually discussed to arrange this among ourselves, to ultimately all the neurologists, radiologists, and neurointerventionists came together to make it successful program. I think today's program was in fact very much successful considering the topic, details of the topic, discussions, question answering, everything. So at the end, once again, I thank Professor Bipul Gupta sir, and he is most welcome to our center. I would like to end the session here. Before that, I would like to request everybody to give a big hand to this today's session, making it successful. Please give a big hand, everybody. Thank you, everybody. Okay, thank you, sir. Thank you, everybody.
Okay.
Thank you.